the surgeon has repaired an extensor tendon, you're not gonna splint them in a lot of flexion, because what have I done? I've just put a lot of tension on that extensor tendon. That's not gonna help the integrity of that repair that the surgeon just did. I'm gonna put them in at least neutral to slight extension to take the tension off of that tendon. I mean, think about it like a rubber band. If the tendon is a rubber band and I've splinted them in a lot of flexion, or even just a little flexion, what have I done? I've stretched that tendon, and the doctor just repaired it. So he's not gonna be real happy with me if their patient comes back in and they're splinted in flexion. That's not an appropriate position. So that's another reason why it's really crucial to understand your anatomy and your diagnosis, and read their surgical notes. Read through those notes to have a better understanding of what the doctor did, so you know more of what you're doing. Not that you have to understand every single word in their op note. I don't, because I'm not their surgeon. but
right.
But I know my anatomy enough to know that he repaired extensor indicis or extensor pollicis or whatever, or that he did a tendon transfer, and so I need to preserve the integrity of that repair by not putting them in a flexion. You want to go to neutral to even slight extension to take the tension off that repair. And it's just the opposite if you'd done a flexor tendon. Think about that as a rubber band this way. If I'm putting them in a dorsal blocking splint, well, it's dorsal blocking for a reason, so they can't extend their wrist back to put more tension on that tendon. The more tension he puts on it, the worse for the integrity of their repair, and then the harder time we're going to have in therapy later, because now that tension is gone. He doesn't have good muscle tone there maybe anymore. So you don't want to splint a flexor tendon. Just the opposite. I wouldn't want to even put him in neutral. I'm probably going to leave him in a little bit of flexion to take the tension off of that tendon. So you've got to really have a grasp on your anatomy with that when it comes to your splinting. Not that you've got to understand everything that the doctor did in surgery. That's not your place.
Or how to pronounce every word.
No, goodness.
They laugh at me because I don't know how to pronounce every word.
And
I'm like,
okay.
You don't have to know that. You just have to.
You don't have to read it out loud to anybody. So,
Yeah.
I mean, that's the good thing is, but you need to know why you're doing what you've been asked to do. So, or sometimes you'll just get an order for a splint that says flexor tendon repair, fabricated orthotic. Well, I don't know the name of that, so he didn't write the name. I don't know what to look up, but I know he did a flexor tendon repair. I want to preserve the flexor tendon. I'm going to put him in a dorsal blocking splint to prevent the extension. He didn't write make a modified Klein art, which is this. That's not always his place to tell me exactly what to make. He just says, here's the diagnosis, make a splint. So sometimes you've got to figure out what splint you're supposed to make based off the diagnosis.
Do you guys, I'm sorry.
No, go ahead.
Do you guys use a whole lot of evidence-based practice, updating these splints or
Yes.
the exercises?
Yes. I mean, orthopedics is nothing but evidence-based practice and following protocols. It's like a recipe. If I have a patient with a rotator cuff repair, I know on week 2 I can start a pulley exercise with him. If I wait until week 5 to start that, I've missed 3 weeks of good exercises that he could be doing. If I start that on post-op day 2, well, now I've messed up with the integrity of his rotator cuff repair, and he wasn't ready for that, and I've done too much to a shoulder that he wasn't prepared for. So knowing your protocol, which is all evidence-based practice, is very important. And it's not that you always have to have it memorized. That's why protocols are written. That way you can refer back to them. Once you do it over and over and over, you'll know your protocols and you'll have them a little more memorized. But I don't always see a flexor tendon repair every single day. So if I get a flexor tendon repair that was in a zone 3, then I need to know that changed my protocol a little bit, because I'm getting them on post-op week 4. So now I'm going to go to my book, look up at flexor tendon repair for zones 3. He's on post-op week 4. Well, now I can start some tenodesis exercises with him. But we might need to back up a little bit because we didn't do therapy. He just started therapy. So we're not going to skip exercises for weeks 1 through 3, but at least I can cover that up to week 4.
And so when I asked Amanda when she got here about the zones, she said the biggest thing was understanding protocol per zone. So, and so the zone, and for flexor, there's 5 of them. And for extensor, there is 7? 8? Okay.
I think 8.
And so
So it's not that you have to have that memorized, but just knowing that a tendon, you know, if they cut a tendon here versus they cut the tendon here, changes how you're going to treat the patient. And if you're unsure, a lot of times your incisions will kind of tell you where the injury was. But if you're unsure, that's not just call the doctor. I'm like, hey, or looking at their op notes. A lot of times their op notes are very specific, and we'll say extensor tendon repair for a zone 3 injury. Well, now I know what he did. I know he's 4 weeks post-op. I can go to my protocol, and there it is. So ortho is very evidence-based. I think that's just following a recipe. If you don't start following the recipe until 3/4 of the way through this patient's treatment, it's not really going to turn out like it's supposed to. You know, if you can start from day 1 with following the recipe just like you're supposed to, they're 3 weeks post-op, they're 4 weeks post-op, they're 12 weeks post-op. And sometimes following things by the book don't always get the exact outcomes. Sometimes you have to kind of back up and punt, and that's okay. Especially if the patient is non-compliant or has other complications or other issues, or they get sick, you know, halfway through their course of treatment and they've missed 3 weeks of therapy or whatnot. So altering protocols, you kind of have to do that from time to time, but you don't want to just totally go outside the box and start doing things that your patient shouldn't do, because they're relying on you to know that. They don't know that. Right.
So if you were to kind of like you said, work their rotator cuff second day after post-op, like what would you do to correct that? Would you just leave them alone until like the second week, or?
No, the doctor already sent you for a reason.
Okay.
If the doctor's already sent them to therapy, they expect you to be doing therapy, not for me to just say, well, I'm not really comfortable treating you right now, and we're just going to give you a few more weeks to heal.
Okay.
I mean, the doctor already wrote the order. They are on your therapy schedule for the day, and they're coming in to see you. So let's say they're 2 days post-op. I've had patients come in the day of surgery. We don't do a lot, but sometimes it's just getting their history, finding out about family support, taking measurements, doing more of an assessment, talking to them about their precautions, because they don't know what they're allowed to do and what they're not allowed to do. And if you wait till week 4 to start with them, you're going to do 1 of 2 things. So they're going to sit at home and not be doing nearly enough for their arm, and it's going to be very stiff by the time they come back to see you. Or they're going to sit at home and do way more than what they're supposed to do, and they've already messed it up. So sometimes those early days, they may be too painful to even do a lot of exercises, and that's okay. You do it what you're allowed to do within their tolerance, because everyone's threshold with pain is very different. So I know on post-op day 2, the protocol says I can do this, but that's when you have to use your clinical reasoning to say, my patient is really too painful to do this, or they're still a little loopy from anesthesia, or they just had a lot of pain medicine and I know they're not totally understanding everything I'm telling them. So for a variety of reasons, I know I can do this on post-op day 2, but we're going to hold off a little. We're going to start with something a little more basic, and maybe we just do some education at first. How do you get in your sling? You know, taking their sling on and off after their rotator cuff repair. That's an ADL, type training that you may be doing them. So it may not always be your rotator cuff exercises that you're doing that day. It may be, okay, do you know how to get a shower? Do you know how to get your shirt on and off? Because you can't reach up with this arm. Don't be moving it once you get home. Let me teach you an easier way to get dressed. Let me teach you how to take your sling on and off. It may be something as simple as that, those first few sessions. But no, you don't wait just for them to feel better or to be able to start doing more before you start with them. The doctor's already sent them to therapy for a reason.
Or what if you like you said, like the second day, and you did let them do the pulley off the door, and it kind of did mess up their shoulder. Would you take them back to the doctor, explain what happened, and then start back? I'm not gonna let them do more than what's appropriate in therapy. Okay. That's your job, is to keep them from overdoing it. Once they get home though, they may overdo it. They may say, you know what, I'm feeling pretty good. I think I can try this. I think,
you know, I'm not having a lot of pain. I did really good in therapy today. I'm going to try to do some extra exercises. And then they come back in the next day and they tell you what all they did. And you're like, yeah, you probably shouldn't have been doing that. I may watch them for a period of time to see how they've responded. You know, is their range not progressing like it should? Is their pain getting worse? Do they all of a sudden have some swelling? So I may monitor my patient for a little while before I'll call the doctor. But if it's something serious, you know, something severe, I'm like, I've got major concerns, then I'm going to pick up the phone and call the doctor. Or I'll ask them to get back in touch with their physician. And I'll say, you know, I really think you ought to let the doctor check that out.
That's like that sudden pain question from test 2. If it's urgent, sudden pain,
Yes.
that's where you got to reach out.
If there's something serious, you know, all of a sudden their incision has opened back up. They have swelling that wasn't there. I'm concerned for a DVT. They've got redness, swelling, you feel heat. You know, if I'm concerned for something along those, my patient's confused, they're showing other issues, I'm going to call the doctor, or, you know, or tell their family, like, you need to get back in touch with your physician. But if it's something where I feel like my patient's just kind of overdone it a little bit at home, I may just give them some time and monitor their situation and then see how they respond. If things aren't going like the protocol says it should, you know, if things aren't really progressing, that's when I'll reach out to the physician and say, hey, I'm concerned about this patient. They're not progressing like I feel like they should, you know, something along those lines. But that's why you have your protocol, so you know what's allowed and what's not, and you can kind of keep your patient on schedule. So, and like I said, you don't have those memorized because there's a protocol for every diagnosis under the sun, you know, so it would be compliant to have all that memorized and to know what to do on this post-op week and that post-op week. But rotator cuffs are probably 80% of my caseload, and I've been doing it for 5.5 years, so I know at week 4 we can start submax isometrics. On week 1 I can start Codman's exercises. On, you know, week 9 I can start TheraBands. Like, I know that now, but at first, you know, when I was really uncomfortable with ortho, I would look at my schedule for the day, I would look at their diagnosis, I would see what week post-op they were, and I'd get my game plan together before my patient came in. And it took some time of me doing that and getting more comfortable with these diagnoses and looking at evidence-based practice and reading protocols and figuring out how to utilize those protocols. I mean, because you can read it, but then you got to figure out how to put that into practice. And that's something different sometimes. It's that implementation part that sometimes is kind of next step.
You've had some of our fieldwork students in the past.
Mm-hmm.
If you were to give this group, they go to fieldwork as soon as they get out of the semester,
Mm-hmm.
and placement allows, any suggestions? What top things would you have them review or know before they go out?
So the great thing about OT is there's such a variety of places you can work, and what you need to know differs a lot from different types of placements. What I did in the hospital is nothing like what I do in orthopedics.
Right.
What I did in pediatrics is not really anything that I did at the hospital. Documentation will look different at different places you go, whether it's online, it's a written SOAP note, it's a point and click check mark box, you know, your documentation is going to look different, but your components of documentation are never going to change. And if you don't document well, it didn't happen and you won't get paid for it. So knowing how to document clearly and quickly is important. You don't always have a lot of time for documentation, and they don't figure in documentation to your productivity a lot of times. So knowing how to document quickly is important, but also effectively. So documentation is important for any facility where you're going to be doing a lot of, I would say, more orthopedic type care. Goniometry measurements are important. Knowing, again, those landmarks in your anatomy for how to do a goniometry measurement. Have I covered any of that yet?
Yeah.
This is totally
We did that in Kines, and then we'll do it again when we do range of motion competencies this semester.
Goniometry is important. So in orthopedics, I'm measuring to the degree. I'm measuring they've got 93 degrees of flexion, of active range of motion flexion. In the hospital, I didn't necessarily document that I didn't take my goni with me to every patient's room, but I would need to say their flexion is within functional limits. Well, what's a functional limit? What ranges are those? So knowing your range of motion parameters, how to do some goniometry, manual muscle testing, because I've done that throughout, kind of regardless of what field you're in. I may document it differently though, like my documentation for manual muscle testing for my orthopedic rotator cuff repair, where that's really what we're focused on is their range of motion and their strength and their function. I may measure, these got a 4 out of 5 manual muscle testing and abduction. But in the hospital, I'm still going to manual muscle test, but I'll document it more as his strength is within functional limits. So it may not be as specific in other areas, but knowing what you're looking for in manual muscle testing is important. Is it functional for that patient, or do you have room for improvement? So that's important. Patient handling skills, whether it's really across the board. Transfers.
We did PNF last week. We did D1 and D2 ranges. What else?
Which are great for neuro and ortho.
So the neurodevelopmental.
And DT. That's also really important with peds. Facilitating appropriate movement in pediatrics with postural support or postural cues or tactile cues, like using your hands to get what you want out of your patient, whether that's a little postural support to correct a movement with their exercise, or getting them to use the right muscles to do what you're asking them to do. I may want them doing internal rotation with a TheraBand, but they'll start doing this motion, and they think they're doing great, but they're not really working any of the muscles you want them to work. So those little tactile cues, just keep your elbow in, keep your back nice and straight, those little tactile cues. So just patient handling skills, whether it's with transfers or just that little bit of cue to get the right exercise. That's important. Knowing how to ask questions is important, and that's a skill I think that takes practice in your patients. It's not always something that comes naturally at first, but just getting comfortable talking to your patients.
Appropriate questions.
Right, appropriate questions, but just having conversation with your patients. So I had a student that was very comfortable with my patients, like almost too comfortable to the point where they're just like, hey, how's it going? And how's your day been? And that's all fine, but they lost a little bit of that rapport with a patient. You still want them to see you as a medical professional, as someone that's there to help them, not necessarily just their buddy they're hanging out with in therapy. Because you want them to respect your opinion, but to still be able to have a relationship with them, but not lose that rapport. But then I've also had students that were really nervous to talk to patients, and the patients can tell. And then they're nervous about following your instructions sometimes. You're like, they really know what they're talking about. When you show you're nervous like that with patients, with asking questions, and you're like, are they really sure? They're really sure that it's okay for me to do this with my shoulder? Like, I don't want to mess this up. So being confident in what you've got to say to a patient. But that takes practice. I think it's just something that takes some practice and some time. But it goes a long way with your patients when they can feel comfortable with you, but still value and respect your opinion and what you've got to say, and know that they can go to you for education. That's important though, just that patient conversation. That's how you get a lot of your assessment sometimes. It's not through, I'm just going to sit down and ask you a bunch of questions, but through just conversation. We've been talking, and I found out my patient's really depressed. Or they're having issues doing their exercises at home because, of their home situation or whatever. So you learn a lot that way. But that's an important skill no matter where you work.
What orthopedic office do you work at?
I'm at Palmetto Bone and Joint. So I worked in our Newberry office today. But I'm typically in our Clinton office. But we also have an office in Chapin. So there's 2 of us OTs, and we kind of rotate between the offices. And I'm usually in our Clinton office. And we've got several orthopedic surgeons now that we're under. So, and it's mostly the hand surgeon that I'm making the splints for. Most of our other surgeons will ask for a prefab splint that I'll order, but our hand surgeon's usually the one that wants the custom orthotics. So, I've enjoyed orthopedics. It's kind of where I always wanted to end up, but I always recommend to students, do 1 year in acute care. That's your best place to get your feet wet, to learn a variety of diagnoses, to learn to work with a variety of disciplines, and to really just, get your feet wet with things and figure out what you want to do and what you don't want to do. Acute care can be a little scary sometimes, but it makes you learn and makes you learn quick.
Yeah.
But I loved acute care. I liked it a lot more than I thought I would. But I did about 3.5 years in acute care. And then the physician came open, and it was just a lot closer to home, and I always wanted to do orthopedics anyway, and so it was just a good time to go ahead and move into ortho. But ortho is what I was always interested in.
You were at Self?
I was at Self Regional before. So I worked in the hospital, and it was me and one other OT, and we covered the whole hospital.
Really?
So
Did
from
you have a coda then, or? I think
Not at the
was one
time.
coda now.
we didn't have a coda at the time. I hope the OT department's grown since then, because it was kind of stressful, just the two of us doing the entire hospital. But we saw everything from ICU, CCU, CICU, to your telemetry units, the orthopedic floor, the med surg floor, like NICU consults. I mean, we covered the entire hospital. So it was a great way to learn a variety of diagnoses, learn to work with the PTs, the speech therapists, the nurses, the doctors, the x-ray techs, your dialysis team, the pharmacists, your discharge planners. It was a great way to really just be immersed in everything.
Yeah, I agree. Newberry Hospital and Palmetto Health in Columbia, those are my two that I learned the most in out of all of them.
You definitely learn a lot, and I think that really gave me a good background before I got into ortho. Because I was already reading op notes and doctor's notes and things in their charts while I'm doing chart reviews before I go assess my patient. I wasn't doing the same thing with them in the hospital as what I'm doing now. I mean, we didn't get a pulley out and do range of motion exercises sitting in their hospital room, but I needed to still know all that information before I went in and assessed them. So it really gave me an opportunity to get my feet wet and learn a variety of diagnoses, vitals, how this medication, they're on a beta blocker, so they're really lethargic today. Well, that makes sense, so it really let me learn what their medications, how that affected their vitals, and how that's going to affect what we're doing today in therapy. And a lot of times you're working with a team providing therapy. You may need the CNA to come help you. You may need the PT to come do a co-treat with you, because that patient's only going to be able to do therapy one time that day. You're not going to be able to do a second round with PT later in the day. You want to go together. Or with speech therapy. I think OT is really that good niche that overlaps in so many other disciplines, where you're really able to work with a variety of other people in the hospital to help, but then to show your importance too. It's a good way to advocate for OT, which is important, because a lot of times, unfortunately, when you go into a patient's room, you're like, oh, my nurse is here. And once you start doing therapy, oh, I got to do PT. And it's a good time for you to advocate for your profession too, with other disciplines. So, but I definitely recommend the hospital or acute care if you can do it. I mean, even if it's just for a year before you decide to get into whatever you're really interested in. So,
Any questions?
no, that was a lot.
Thank you.
Thank you for letting me be here.
Thank you for coming.